May I ask you, anyone still using gene expression? Nina, do you use gene expression on the bone marrow? Do you do targeted sequencing? Do you do whole genome sequencing? Do you do anything else?
I really don't, because I feel like, and I will fully admit that, and we talk about this, sometimes I just don't know what to make out of this various different groups of genomic data, and different groups have presented different things, and it's not widely used, and by the time I get the data, the patient's already started on something, so it's hard for me to use that data, so I don't use it.
Alfred, do you use gene expression profiling, targeted sequencing, whole genome sequencing?
When we do the diagnostic marrow at our center, we do targeted sequencing and as part of an effort across all heme malignancies to do that. But the data are not very useful for making clinical decisions. And the gene expression profiling, like the various tests that are out there, we've never used those, no.
So the targeted sequencing you do you do matched germline also, or this is only somatic profiling? Only somatic. And this is for somatic mutations, is it also for VDJ sequencing?
No.
So there is no signature generation for MRD tracking going on at this point?
Correct.
How about you, Ajay?
I think where I would be interested, I'm not doing it now, would be this, we talked about the 17p, right? FISH doesn't give you the whole answer. What's going on in that 17p locus? That would be very important, and I think would have actionable implications now. But I think—
You can have a locus if you're not buying.
Right. But then the other question, I think, is in the relapse setting, these targeted sequencing can potentially identify novel targets with using drugs from other cancers, although I think the success with that is limited. But I think at the end of the day, if you always ask that question, you know, as a medical student, we teach them, if you're going to order a test, be prepared to answer how it's going to change your management. And so for the vast majority, similar to MRD, if it's not changing your management, it's fine to do it for academic purposes, but I think in a routine community setting.
And I've done more of that targeted sequencing in the relapsed refractory setting when you're trying to generate more creative options for patients. And I think it would be important to do it at the time that you're thinking of using and kind of outside the box targeted therapy, like a BRAF or a MEK inhibitor. It's probably better to do that sequencing at the time that you're considering using it, because those things can change over time and you can get allelic fluctuations over time.
And how about you, Ola?
So we do sequencing for the purpose of clinical trials. Like we all here around the table have small molecules that block. We have MEK1/2 inhibitors, we have BRAF inhibitors. You're looking for mutations in the MAP kinase pathway, and there could be other mutations as well. So for that reason, we do for those patients that are looking for those types of options. And we have started to do that a little bit earlier, also to have the data in case the patient continue to relapse, because the timing obviously can be a factor that kicks patients out of the trials. If you don't have the data available for targeted drugs, that may not be an option for that patient. We just published a paper we have, for research purposes, designed a targeted assay where we capture the entire IGH locus and we spread baits throughout the whole genome. So it could be this sequencing approach replace FISH and cytogenetics. And we did 150 cases that we had all the SNP array and FISH data for. And we were able to show more than 99% both sensitivity and specificity. And then in addition, we had a somatic mutation. So we then could identify biallelic P53 in activation. So it's not yet in clinical care. And I know there are other groups. I think Mayo has something, Dana-Farber has. I don't know if your institutions have similar approaches. I think the field definitely is going in that direction. But I think there's some more work that needs to be done to standardize this.
I think, and we're seeing it with venetoclax, probably the first time where a gene expression profile, transcriptional profile, is predicting sensitivity to a drug in a really compelling way. And so it seems to be that T1114 myelomas respond to venetoclax, but there probably is a subset of cyclin D1 driven myelomas that are not carrying the T1114, and those would presumably be sensitive to venetoclax. And if we have more drugs coming out like that, where we can tie sensitivity to specific gene expression profiles, I think we could see that testing become more part of our mainstream care.